My name is Eddy. I'm an intensivist from the University of Toronto, and it's my pleasure to provide this introduction to an international leader in critical care who is helping to advance our field at the cutting edge of extracorporeal support, ARDS, sepsis, and surgical critical care, my colleague and my friend, Dr. Pauline Park. Pauline?
Thank you for that kind introduction, Eddy. And thank you to Professor Vincent for putting together this really wonderful panel and for the opportunity to speak today. It's a distinct privilege to join this very new virtual session and close it. The topic today is ECMO, Future Directions. And I have no disclosure. But I will say that those who have knowledge don't predict, and those who predict don't have knowledge. So I guess that's my disclaimer for today, but I have no disclosures of conflict of interest. I think the best way to look at the future is to understand the past, and I want to recognize Bob Bartlett, the main driver and inspiration for me and for so many others. By pursuing his singular vision, Dr. Bartlett showed me the wonder of seeing a life saved that I thought was lost. It's a humbling thing to see that all that you had previously thought was true might not be the case. So, Bob, I want to say that your collegiality, your friendship and example, and vision have changed my life immeasurably, and I am grateful. So, looking at the past, here's a quick trip over the last almost 50 years for adult respiratory ECMO. It's an abbreviated history in a few steps. The first adult patient who received ECMO for respiratory support was an adult polytrauma patient, and technique was much different at that time. He received veno-arterial ECMO, high-pressure ventilation. They used a Bramson lung and a roller pump. During this time, randomized studies did not clearly show an advantage to ECMO until 2009, when the CSER study was published. Giles Peake presented in The Lancet a 31% mortality reduction in referral of patients to a specialized center that had ECMO capability. But we really didn't see a large uptake until H1N1. And you can see here from the also adult respiratory cases that really the majority of cases have been in the last decade for adult veno-venous ECMO. Moving forward another 10 years, Alan Combs and the REVA group published the Aeolia trial, demonstrating an 11% increase in probability of survival for patients randomized to receive ECMO for respiratory failure. The study was stopped for statistical significance, but there was quite a bit of debate about whether or not we should continue to pursue ECMO. And Bayesian analysis suggested that the data supported considering ECMO for the most severe cases. And now in 2020, we have COVID, and the ELSO registry is collecting large amounts of data on patients who have received ECMO and COVID. Initially, I think most of us were a little circumspect about offering high technology therapy in the case where we were already strained for resources and PPE. It was unclear what the prognosis was in this new viral infection. But as we gained experience and became more familiar with the disease, ECMO started to be applied. I think Ryan Barbaro has over 2,500 cases in the registry now, and survival is running over 50%, which is remarkable thing when we think that perhaps at the beginning, just 6 months ago, we thought that patients who were ventilated with COVID were almost inevitably going to die. So the question posed for this session is, what do we see in the future? What will ECMO look like in even just the next 10 years with all the change that we've seen in the last 10 years? And so for this quote, I have that the only way to predict the future is to invent it. This has been attributed to many people, including Abraham Lincoln, but I'm quoting Alan Kay from the computer science world. So the evolution of ECMO care, really, where are we now? We're in a phase of rapid dissemination of this technology. I think in the beginning, when you look at how technology spreads across the medical field, there are pioneers and early adopters, At that time, it's a new paradigm of care. All hypotheses are open to be tested, and there's ongoing data collection. The Vanguard Group is a group of expert centers. They refine practice, conduct clinical trials, expand education, and continue data collection. And now we're moving towards where a place where people are questioning whether ECMO is a routine part of critical care, where many centers can be involved, and issues such as standardization and certification, whether or not there should be regionalization at some level, are being discussed. But always we have to continue data collection and try to inform where we are going next. How do we invent the future? Using a combination of vision, carrying on Bob's original premise, going on with collecting data, working together and collaborating, and dedicating ourselves to improving the care of our patients is how we can impact the future of ECMO. Has to be done intentionally, with science and a team approach. This is difficult in the contemporary media blitz that's ongoing with the viral spread of information through the lay press and through medical preprint servers and the medical literature. All of us trying to digest what should we do, what has been done, what should we do in the future. So what can we do better in ECMO? I think there's a large laundry list of things that we can always do better in, but I've made a short list of 8 topics. So I think the first thing we could envision is what would make our lives and our patients' lives better is making ECMO smaller, miniaturizing the components. How small can we actually get and give adequate support? Making it smarter, incorporating computer algorithms and servo feedback so we can have response for pump pressures, dynamic flow titration for changes in oxygenation and patient demand. Can we make it safer? Can we go without anticoagulation for long periods of time? This is the holy grail of the blood prosthetic barrier, trying to make the perfect non-thrombogenic surface. But if we can do this, we can bring the complication rate from bleeding and thrombosis down. We still have a measurable complication rate of neurologic injury, and bringing that down will make ECMO safer. And can we go longer? Can ECMO evolve into a destination therapy in parallel to, say, cardiac support, where there's some at least partially implantable components? We would have to address the oxygen source, the battery power, and importantly, the patient aspects, the psychosocial support and rehabilitation to return to a fuller life. How can we do ECMO better? It's applications and organization. Can we do it early? Not just earlier ECMO for VV support, but can we extend ECMO support to resuscitation and get through the ECPR barrier? Can we help out of hospital arrest resuscitation in a meaningful fashion to improve patient outcomes? We want to be informed. We want to refine the indications. We continue to look at our previous observational data. I think that there's still a large amount of variation in care, different protocols, trying to understand what it is that we all as a community do to try to make these most critically ill patients better. I think the impact of big data, waveform analysis, continuing observational and clinical trials can help us make decisions on how to make ECMO better. We want to be more efficient. The question of cost effectiveness for high technology is always an issue when we talk about societal equity. Who has access to care? How much care can we give? How can we optimize the resources to best serve our patients and our communities? And can we be organized better? Is there value to destination centers for acute respiratory failure, for patients who are coming in with acute viral or other illness, and for chronic respiratory failure, where patients with chronic hypercarbia may be treated with ECCO2 or just a short-term therapy, and then for pre-transplant. So one scenario, and I made this for this, and probably won't want to look at it in 10 years. But since the question is, what is the future going to look like between 2020 and 2022, we hope that COVID wanes and that we enter a new normal of global health with successful mass vaccination and return to what we all consider to be our normal lives. In 4 years, I hope there's continued standardization and we have organized center development with certification for ECMO, specialization, ongoing education, perhaps some consolidation for efficiency and quality of care. All through this time, we should be refining our indications, continuing data collection. We must inform our decision-making and try to evolve best practices that apply to all centers for all patients, while still attempting to maintain a semblance of precision medicine and individual care that we judge as physicians. I think by the end of the decade, we will see ECMO moving as a destination therapy, and it will no longer be a bridge to nowhere, but that there will be a bridge to ECMO. This will be following the VAD lead. We'd have to look at alternative long-term cannulation strategies and pump design. And if it's possible, we might get to wearable ECMO. With the awake and mobile patient, oxygenation source and energy sources will definitely be dependent on new technology, but we have to think of the future that this is possible and this is where we should be going. So in 2030, what is the glimpse for the future? Is it what I've outlined? We can't know, but we know that research, analyzing the data, and applying the data appropriately will be the best way to make patient care. And I've got on the next slide some people who are also part of the future. It's not by any means everyone, but Daryl Adams from Columbia has been working on ECMO guidelines, asking the questions of who should be receiving therapy. Carol Hodgson, dedicated to ICU mobilization and ECMO outcomes. Ryan Barbaro made marked changes and improvements in the ELSO registry, collecting all the data that you'll be seeing coming out in publication soon. Janelle Badalak, up and coming physician from the University of Washington, pioneering online education through the internet and free online medical education. So I would like to thank everyone for the privilege of showing these slides and articulating a possible vision for the future ECMO. And I want to again thank the organizers for the privilege of speaking. Thank you.